Hi, welcome to the session of Learn Your Family Business and Prevent Cancer. With us today on the screen is going to be Dr. Ellen Werner. She is a medical oncologist at the Sunnybrook Odette Cancer Center, and also Melissa Rosen. She is a director of training and education at Sharsheret, the Jewish Breast and Ovarian Cancer Community. She's also a two-time personal cancer survivor, so she's coming from a place of professional and personal knowledge. So in preparing the session, which is focusing on things that you can know from your family history to prevent cancer, specifically things that have a genetic component, but not only. We were talking about, we're really heavy duty in the conversation about cancer prevention and screening. And I believe it was Melissa who said, she'll talk about it later, that we often put ourselves last. That women often say that they're like the least important in their family. Of course, they're not, but they take care of everybody else's appointments and haircuts. And often they put themselves last. And people even push off their mammograms all the time. And I very sheepishly said, I've actually pushed off 2 mammograms in the past year. So I am totally guilty of doing many, many mistakes that can have, unfortunately, some very serious consequences. So we're so lucky today to have 2 experts with us. I will be framing some Jewish and halachic issues surrounding these issues. I want to just from the outset say that I am not giving psak halacha. I'm not giving any halachic advice for anybody. It's always important to consult your doctor, of course, to consult people from different support communities, and also your local Orthodox halachic advisor to figure out exactly what is going to be the appropriate steps to take. So Ellen is going to start out by framing why some of these issues are so important.
So let's start with a case. Izzy is a 63-year-old dentist who was recently diagnosed with pancreatic cancer. Don't put him on your tell-him list. My fictitious patients always live till 120. Although Izzy has no family history of cancer, he's offered genetic testing in the context of a research study, and he's found to have an inherited BRCA2 mutation. A mutation is a genetic abnormality. BRCA2, US they call it BRCA2, they're the same thing. But people who have these mutations have a very high risk of developing certain cancers. Next slide, please. So a bit of genetics already. Our bodies are made of trillions of tiny little cells, and each one of these cells contains an identical copy of 2 full sets of genes, each one inherited from one of our parents. These genes are the software that tells our bodies how to develop, how to function, and the only difference between one cell in one part of the body and another cell in the other part of the body that look and act completely differently is which genes are turned on or off, and that too is controlled by genes. Now, since only Hashem is perfect, we have all inherited mutations from each of our parents. And these will be in every single cell of our bodies. Many of them cause no effect on our health whatsoever, but some will increase our risk of certain diseases, may even guarantee that we'll acquire a certain disease. And each one of our children has a 50% chance of inheriting each one of these mutations. So there are 2 ways that these mutations that can affect our health can be transmitted from our parents. And most of the Jewish genetic diseases that we're all familiar with, for which testing before marriage is strongly recommended, are autosomal recessive. So let's take Tay-Sachs as an example. In order to develop Tay-Sachs, one has to inherit a mutated copy of the Tay-Sachs gene from each parent. So looking at the family illustrated on the left, the father only has 1 mutated gene, so that he's healthy, and if he marries a woman with 2 normal genes, then on average, half the kids in their family will have the Tay-Sachs mutation. They'll be carriers, but they will all be healthy because they'll all get a normal gene from their mothers. But the family on the right, both parents carry the mutation, and each child has a 25% risk of inheriting both mutations and developing Tay-Sachs. Next, please. On the other hand, genes that cause cancer, such as the BRCA2 mutation that Izzy has, are autosomal dominant. That means that having only 1 copy, for example, of the BRCA2 mutation, like the father in the illustration, will give him an increased risk of cancer, and which each one of his children has a 50% chance of inheriting that mutation and also having that high risk of cancer, regardless of who he marries. Next slide, please. So this is Izzy's family tree or pedigree. Circles are women, squares are men, slashes are deceased people, and the tiny little colored squares indicate people who've had cancers. So Izzy is the only one in this family who's had cancer, as you can see. And because his mother, her brother, and their parents all reached the age of at least 75 without developing cancer, it's highly unlikely that they had the BRCA2 mutation, and much more likely that he inherited it from his father, who died at a young age, and whose sister and parents unfortunately perished at a young age in the Holocaust before they would have had a chance to develop cancer. So genetic counseling as testing is offered to each of his brother, his sister, and his 4 children, who all have a 50% chance of having the same BRCA2 mutation. And genetic testing is critical for this family because those who carry the mutation can be offered strategies to greatly lower their risk of cancer or to catch it at a very early stage. All 4 children decide that they would like to come together for genetic testing, but when they arrive, Noah, the youngest, shocks the group by declaring that she has just read an article in a Jewish magazine recommending against testing, and she refuses to be tested. And here are the 5 reasons summarized in the article as to why testing is not recommended. First of all, they argue if you discover you have a mutation, that will cause fear and anxiety. Number 2, many mutation carriers never get cancer, and even if they do absolutely nothing to lower their risk. Number 3, many cancers are cured. Preventive surgeries can have negative effects on our health, which might even be worse than the treatment for cancer. Number 4, we can give people very intensive screening based only on their family history without having to test them. And number 5, discovering one has a mutation ruins marriages and makes it impossible to marry off one's children. We hope that by the end of this session, you'll be convinced that for high-risk families, the benefits of genetic testing for these cancer-causing mutations greatly outweigh the risks. And now I'm going to hand over my e-podium to Melissa, who's going to give us some strategies about how to deal with some of these issues.
Thank you so much, Ellen. Okay, so you have a basic understanding now, and you've been left with the question of genetic screening. And let's be honest, sometimes it's not an easy decision. Sometimes the information you need to gather to determine whether genetic screening is right for you is hard to come by. So as Ellen referred to, it could be that many of your relatives perished during the Holocaust, and so you simply don't have that information, that health history. If someone is adopted, they also might not have that health history. And then finally, family size. If a family happens to be smaller, or if there's a preponderance of men in that family, it may be, even though men are impacted by this, it may be that cancer hasn't expressed itself in a significant way, and so you might not know if there's a family history. What I want to say is if you fall into one of these categories and don't have that information, you're not really at a disadvantage. You're really sort of where the general community is, and you'll use other pieces of information to decide whether genetic screening is right for you, and you're going to follow all the same health advice about living proactively anyway. So that's important to keep in mind. The other thing that's important to keep in mind is these aren't easy conversations, no matter how life-saving the information is. For some families, this is a very, very difficult conversation to have. It could be individual family dynamics, or it could be that the individual community you're in, that culture, considers this something not to talk about. So I want to give you a couple of ways that you can get beyond that, because again, life-saving information. So for some families that I work with, they're sitting at a holiday meal and they have the conversation right there. But if your family isn't that type of open, then the best way to do it is to have one-on-one conversations. Do it now while people remember. Very important. You have one with a grandparent, one with an aunt, a parent, a sibling, whoever remembers. And promise them privacy. This isn't something you're going to be sharing in a public forum, either in terms of the family or certainly not within the community either. And then, most importantly, explain what the ramifications are. For anyone who's familiar with genetics, you know that there are certain mutations that exist that we should never know from, where if you have the mutation, you're going to have the disease and you just wait. Let me be clear. That is not the case with these mutations. These are known as actionable mutations, which means you can take steps, and there are a lot of different steps you can take, choices you can make. You can take steps to reduce risk significantly, or, as Dr. Warner said, to find at a very treatable stage. So this is life-saving information, a gift somebody can give to their family, to their children, their grandchildren, siblings, things like that. And so that's what makes this so very important. Okay, I'll definitely be back later, but right now I want to turn the next slide over to Atara, who's really going to share some of the halachic implications of this information.
I'd like to frame two separate issues. One is going to be the concept of prevention in halacha, preventing health issues in halacha, and the second is going to be something that's on a lot of people's minds, which is potential shidduch issues. So in halacha, I think it sounds, most people at this point understand that there's a concept of treating illnesses. There was a machloket at some point about whether one should attempt medical intervention, but at this point, the entire Jewish community agrees that we take very strong action when there's a disease. But there's also a concept of preventing a negative health occurrence that could happen. We could point to two psukim that are in Devarim, Perek Daled. We have v'nishmartem ma'od lenafsho seichem. You have to protect your soul. Watch v'nishmartem, like Shmor. You have to guard your soul very, very carefully through doing things to make sure that you will live a good, strong life. And Raki Shmer l'cha u'shmar nafshacha, that you have to, again, very similarly, that it's important to guard and watch over yourself. And the way that we do that is really by being very careful about preventing negative health occurrences. Among things like, wearing seatbelts and not smoking, are things that come to mind very, very more commonly, but also included that are the preventative actions that you could take by doing the proper screenings that can save lives down the line. Something that I could say, because I'm sure she's not watching right now, is that I have a daughter who is now of marriageable age, and I'm really starting to think about all sorts of shidduch issues. She's 21 and a great catch. So there are all these different things that people are nervous about, that if I disclose, if I find out that there's a BRCA gene mutation in my family, that's something I'm going to have to disclose, and that could affect that could affect the marriage choices of my children. Is something very, very common, and one of the main reason that people might choose not to do this testing. I like to draw a parallel to a tshuva that Rav Moshe gave about the question of somebody who is divorced, who normally covered her hair. Is she allowed to no longer cover her hair upon divorce? And Rav Moshe said that there's a distinction between things that are deal breakers and non-deal breakers. If somebody there are certain things in life that are deal breakers. If somebody is, God forbid, an abusive person who might abuse a spouse, that is something that must be disclosed, because that's a match that should never, ever happen. But there are many things in life that are uncontrollable, and many things that are not yet revealed or not even known, they're not deal breakers. When we get to know the person, we might get to really like them. We might create a connection, realize the person's a good spouse. So he said, leaving aside the issue of erva, about uncovering hair, whether that's allowed or not, he addressed the question of whether uncovering somebody's hair would be tricking a person, like pretending that she was never married when in fact she was divorced. And he said, this is information that people, all the time get remarried. And if a woman not covering her hair is going to enable her to meet somebody, and then they might really hit it off, fall in love, and get married, then that's something that it's not considered having a skeleton in the closet that's not revealed, and you're hiding information. So that would be a parallel to this kind of situation. You don't have to say, "Hi, I am blah 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 on my first date, and I have a BRCA. I'm a carrier. I'm a BRCA2 carrier. That's not the way that things work. These are not deal breakers. As we're going to learn, these are manageable, actionable things, and it should not be a reason for a person to choose to not to get this testing done. We're going to now move on to Ellen is going to take it away and get back into the nitty-gritty science.
So hereditary cancer, when we see cancers in a family due to an inherited mutation, we often call them hereditary cancers, but that's really a misnomer. You can't inherit cancer. You can only inherit the high risk of developing cancer. So Izzy had a very small family, but one of the clues in larger families that we're dealing with hereditary cancer is that we see multiple cases of specific cancers in several generations on the same side of the family, and these cancers tend to occur at an age that's much younger than you would expect in the general population. And these mutations, interestingly, that we've discovered to date tend to affect two types of genes, either genes that control cell division, which makes sense, or caretaker genes that are designed to fix mutations that develop over the course of a person's lifetime, and they're defective. So could I have the next slide, please? So the most common hereditary cancers are hereditary breast cancer and hereditary colorectal cancer. That's cancer of the large intestine or rectum. And in Jews, 90% of hereditary breast cancer is caused by BRCA1 or BRCA2 mutations, so let's focus on those. 1 out of every 40 or 2.5% of Ashkenazi Jews is born with a BRCA mutation, either BRCA1 or BRCA2. That's a 10 times higher frequency than in the general population. Sephardic Jews are somewhere between the two in terms of risk. In Ashkenazim, these mutations account for 10% of all breast cancer, 25% of all ovarian cancer, and 10% of all pancreatic cancer. And the younger a person is when they develop the cancer, the more likely it is that it's BRCA related. And I apologize for the building in the background. I wasn't expecting this. So this slide shows the risk up to the age of 70 of men or women with BRCA1 or BRCA2 mutations developing these specific cancers compared to the risk in the general population. And as you can see, men have an increased risk of prostate and breast cancer, but it's really the women who bear most of the burden of these mutations, because they have over a 50% lifetime risk of developing breast cancer and a very high risk of developing ovarian cancer, which has only a 20% cure rate. Next slide, please. So if we test Noah, Izzy's daughter, and find that she has a BRCA2 mutation, what can we offer her besides just bad news? So ideally, we would like to offer her ways to reduce her risk of developing ovarian cancer or breast cancer, and preventing all those cancers to at least detect these cancers through screening at an early and curable stage. So next, please. So starting with risk reduction for ovarian cancer, if a woman takes the birth control pill for 5 years or more, her risk of ovarian cancer is cut in half without increasing her risk of breast cancer. That's fabulous news, but it's not good enough. And that's why for such a lethal cancer, and that's why we recommend that once a woman has completed her childbearing, that she have her ovaries and fallopian tubes removed by the age of 40 at the latest for BRCA1, by 45 for BRCA2. So why do we have to take out the fallopian tubes that connect the ovaries to the uterus? Because pathologists actually have found that most of these cancers actually start in the fallopian tube next to the ovary, and then it spreads to them. So you need to remove both. In order to prevent most of the terrible side effects of going into an early menopause and the health risks of that, we recommend that women who haven't had breast cancer go on hormone replacement therapy up to the age of 50, and that won't increase the risk of breast cancer. Next slide, please. Removing the ovaries and tubes is particularly important because there is no screening regimen to date, unfortunately, that has been proven to reliably detect ovarian cancer at an early stage. So another benefit of removing the ovaries is that it decreases the risk of breast cancer. That's great. And so would going on an anti-hormonal therapy such as tamoxifen. But the most reliable way to lower the risk of breast cancer is to remove the breast surgically, and that's called risk-reducing mastectomy, and almost always done at the same time with a breast reconstruction. Next slide, please. So risk-reducing mastectomy reduces a breast cancer risk by over 98%. And the best operation one can do today if a woman hasn't had breast cancer is called skin nipple sparing mastectomy. And here the skin and nipple of the breast is just left exactly the way it is, and with like a tiny little incision, the breast is literally scooped out and replaced with either soft implants or the woman's own abdominal tissue, giving her a tummy tuck at the same time. This looks great, feels very natural, but the nipples will be numb probably, and obviously you cannot breastfeed from these breasts. So as effective as this is, there are many women, and this is no criticism, who cannot bear the thought of losing their breasts. And there are also women who say, well, I'll do the surgery, but first let me at least have children and be able to breastfeed them. Unfortunately for them, there's a wonderful alternative. There's very effective screening with a combination of mammography and MRI. Next, please. Next slide, please. So we recommend that all women have breast screening with mammography, regardless of family history, risk factors, anything, starting at age 50. But for BRCA mutation carriers, they need to be screened at a much earlier age, more frequently, and make sure that their screening includes magnetic resonance imaging, MRI. With MRI screening, the chance of surviving breast cancer, if it's detected this way, is more than 90%, which is fantastic. But the real question is doing screening for one's lifetime as safe as having risk-reducing mastectomy? And we can't do absolute comparative trials, but it appears that it may not be quite as safe, but the difference is small. And that difference is going to get smaller and smaller over time because breast cancer treatments are getting better and better and more effective. Next slide, please. So what about the men? We mentioned they have an increased risk of prostate and breast cancer, and they do. Fortunately, the breast cancer tends to occur at a late age. It's not that common, and we don't really know whether screening is effective or not for this group. Prostate cancer, however, is a different story. Especially for BRCA2, it tends to occur at an earlier age and be much more aggressive, and we recommend that these men start prostate screening in their 40s. Next slide, please. So we've done a great job over the last few decades of taking breast cancer out of the closet and making people talk about it, feel comfortably. Unfortunately, we're not quite there with colorectal cancer, and that's a pity because colorectal cancer is the third most common cancer in men and women. A third of these cancers are fatal, but it can be prevented in many, many cases, and most of these cancers are actually curable if they're found early. And about a third of these cancers, there's a family history of colorectal cancer. And also in 5 to 10%, we find a mutation on our panel of genes that we can offer appropriate people. Screening for colorectal cancer is particularly effective because it not only finds early cancers, it can actually find precancerous polyps that can be removed before they actually turn into cancer. We recommend that people in the general population all get colorectal screening starting at the age of 50. But for people with a family history of it or a known mutation, they again need to start earlier, do it more often, and make sure that their screening includes colonoscopy. Next slide, please. People with hereditary colorectal cancer, in other words, a mutation, men or women, have a 50% lifetime risk of getting colorectal cancer. Interestingly, taking regular aspirin significantly lowers that risk, but not enough to preclude the need for screening. And in some of these mutations, there's also a high risk of other cancers, most notably uterine cancer in women. And for this reason, once they've completed childbearing, we recommend a hysterectomy. Next slide, please. So the last thing I'd like to talk about is the possible results you can get when you have genetic testing. So a negative result, no mutation, is only possible when you already have a mutation known in the family. So for example, if we test Izzy's sister and she doesn't have that BRCA2 mutation, we can tell her, this is great news. Your risk of developing breast or ovarian cancer is no higher than any other woman your age with similar personal risk factors. But in most cases, we don't have a mutation in a family. And when we don't find a mutation in a tested individual, we call that indeterminate or like unhelpful or whatever you want to call it. So it's sort of a negative, but maybe not a negative. And that's because it's possible that person really doesn't have an inherited mutation, or it's possible that they do, but it's in a gene that we have yet to discover and that for which testing is not available. and there are new genes being discovered all the time. In this case, our recommendations in terms of prevention and screening are based on the person's family and personal history. And we do recommend that they go back to the genetics clinic from time to time and find out whether there may be new genes now for which they're eligible for testing. So we've talked about the implications of a positive test, but it's very important when someone does have a gene, a gene mutation, that every single blood relative who may also carry that gene is informed and given the option of having testing. And the last possibility is something called a variant of uncertain significance. This is, next slide please, this is a mutation that may or may not increase the risk of cancer. And that's because we haven't done enough research on these genes. We don't have those answers. Most of them eventually turn out to be benign. So we treat this as preliminary, as an uninformative test. And we, again, screen and advise people based on the family history. But it's very important that people go back to the genetics clinic from time to time. You can just call them and find out whether these whether these mutations have been reclassified, because occasionally they will be reclassified as a truly pathogenic mutation that increases cancer risk. So I've just given you a whole ton of a lot of theoretical information. And again, I'm going to pass the batons over to Melissa and Natara, who are going to tell you how you can actually actualize this and take action and do something useful for yourself and your family.
Thank you. That was great information. Before I start, I just want to make a note that if you have any questions that come up throughout the presentation, please put them in the chat box and we'll have some time to answer toward the end of the presentation. Okay, so now it's time to take action. You've been given a lot of information. It can be scary, so let's make it easy. We're going to talk about several different kinds of action taking, but let's set the stage here. First, address the emotions. You can acknowledge that this is scary. Absolutely. I think that is a very important thing to do because it informs the way you'll address this with doctors, with families, with genetic counseling. Then gather or simultaneously gather the necessary information. So the necessary information before genetic screening would be, again, to talk to family members, find out what cancers are in the family, the age of diagnosis, and then note those down with your relation to that person. And I want to encourage you to not just deal with breast or ovarian cancer. As you've seen, the BRCA mutations and other similar mutations impact risk for prostate, pancreatic, maybe melanoma, GI cancers. So write any cancer down, because the reality is the field of genetics changes so rapidly that something that may seem irrelevant today might be very relevant, even just 2 or 3 years down the line. If you're looking for a way to gather that information, you can search on the Sharsheret website, Family Tree, and there'll be a blank family genetic pedigree for you to fill out to bring to your doctor. Once you have that information gathered, any known mutations, any cancer diagnosis, take it to the doctor. That doctor may be an oncologist if there's one already in the family, but that's usually not who you go to. You usually go to an OBGYN, a primary care physician. For some, it might be a gastroenterologist or a urologist. You might even have the conversation with a genetic counselor. Share that information and decide together whether genetic screening is appropriate for you. Now, I know we're dealing with an audience from several countries here, and every country has their own recommendations. But just know that if you are of Ashkenazi descent, for sure, but also if you are of Mizrahi or Sephardi descent, possibly as well, you're not of average risk. And so already not being of average risk means that it might be appropriate to have this screening. Okay, once you share that information and the results of any genetic screening with your doctor, you're also going to have a conversation about your own personal health history. They'll ask things about whether you personally have had any cancer, whether you smoke and other risk behaviors you engage in. I hope nobody here smokes. Whether how many pregnancies have you had? All of these things taken into account, talk about your risk, not just for cancers in general. So you have the screening results, the genetic screening results. You've added your information, your personal information, and you're creating a customized screening plan. Genetic screening and other health screenings. Other health screenings might include mammogram, might include colonoscopy, might include a PSA, blood work test, things like that. You're going to have that guide to take you forward healthfully. Let's talk about, before we go to these other types of screenings and other health behaviors, let's talk about genetic screening. Just a note that this isn't something you do on the spur of the moment. This is something you give thought to. You have informed conversations about, and you make an active decision. It isn't a passive decision to make. So if you decide you want the screening, I'm going to recommend very strongly that you connect with a genetic counselor. So it may be that your doctor has written a prescription and has a genetic counselor and a lab they work with. It may be that the doctor just writes the prescription and sends you on your way, and you need to find out where to get the screening and genetic counseling on your own. But I do want to say that these type of genetic screenings really need genetic counseling both before and after the screening. Where do you get screened? Well, depending on what country you live in, it might be a local doctor, a lab, a clinic, or you might choose to do this remotely. So there are two types of remote screening possibilities. One is a direct-to-consumer opportunity, and these only include BRCA mutations and not some of the other mutations that we've referred to here. The other thing to know about direct-to-consumer screening is that right there on the results, it does say that before you make any medical decisions, this needs to be redone, confirmed. The results need to be confirmed with a medical grade screening. So if you want to do this remotely for whatever reason, and you are looking for medical grade screening, then one place you can look is JScreen. JScreen is for America, for the United States. And they also include genetic counseling. They do it at a reduced price, and it is a medical grade screening. And all you do there is go onto their website, answer some questions, educate yourself a little bit, and they'll send you a tube you can spit it into. It's a saliva tube. If you go to a lab, it might be saliva, it might be a simple blood test. Again, genetic counseling before and after to help address the emotional issues as well as the medical issues. And then something we haven't brought up, and here I'm speaking about, specifically speaking about the United States, but I'm sure there are similar issues in both Israel and Canada. Some legal concerns. So in the United States, you can't be kicked off of health insurance because of the GINA Act if you carry a mutation, but you can be denied long-term care insurance or life insurance. So if you think there's a chance you might test positive for a mutation, that's something you take care of beforehand. And that's something that a genetic counselor will let you know about. Afterward, not only will a genetic counselor explain your results, but might explain some of the things that Dr. Warner went into. For instance, if you have a strong family history of cancer, but you've tested negative, that's not necessarily a good thing, because you still need to treat yourself as if you were high risk, because you are. Very likely there is a familial mutation that has yet to be discovered yet. So a genetic counselor deals with all types of those things, as well as the emotional component of carrying a high risk genetic mutation. And as Ellen mentioned, It might be that you'll go for screening, genetic screening every few years as new mutations are discovered. So now we've talked a little bit about what you're going to do, how you're going to take action in terms of genetic mutations, but let's talk about how you're going to take action in terms of life in general. So when I first started working at Sharshart many, many years ago, I was shocked to learn that there are behaviors that reduce your risk dramatically, whether one carries a mutation, a genetic mutation, or not. And the reality is about 1 in 8 women will be diagnosed with breast cancer, whether they carry a mutation or not. So even if, thank God, we're free of mutations, we are not off the hook in terms of being proactive about our health. So what are just some of these? Obviously, eat well. I'm not saying to go on any restrictive diets. Those are not sustainable, and some are not even healthy. What I'm saying is that most of the time when you sit down, if your plate is filled with colorful vegetables, whole grains, and lean proteins, every once in a while you can have something. A good example, we have Shavuot coming up. Can't have Shavuot without cheesecake, but you probably don't need 3 different flavors of cheesecake, no matter how much we want them. It's the perfect example, moderation. We all know that drinking alcohol in moderation and not smoking reduce risk. Move more. Not asking anybody to run a marathon unless you're interested in running a marathon. But what I'm asking is for you to take a walk with a friend or your children or a partner every day or most days a week. Park far away from the entrance to a store. If it's only 2 stops, don't get on the tram, just walk them. Those kind of things actually count toward moving more. And of course, something very difficult, which is reducing stress in our lives. And stress actually leads to inflammation, which increases our risk for so many illnesses. The thing about the behaviors on the screen right now, they are win-win. They don't just reduce risk for breast cancer or ovarian, but for all cancers. And not just for cancer, but for heart disease and diabetes, perhaps dementia. These are win-win behaviors. So whatever you can do to reduce stress in this particularly stressful time. The bad news is there's more stress in all of our lives. The good news is access to stress-reducing behaviors or modalities are online a lot more at no cost than they ever have been before. So you can check out yoga or meditation or rhythmic breathing or any number of stress-reducing behaviors online. And then this last one, which is so important, and it's how we began the session, right? Tara mentioned how we put ourselves at the bottom of our own to-do list. We need to stick with the plan that was created, right? You've put all this effort into creating a plan with your healthcare team, so stick with that plan. Not only make your appointments, but keep those appointments. At the beginning of the pandemic, I know that at least in the United States, all regular cancer screenings were canceled while we knew while we learned what we were dealing with. Today, that is not true. All regular, non-urgent cancer screenings have resumed, and these places know how to keep us safe. I'm assuming the same is true in Israel and Canada. And if you put your screening, whatever it was, off because of the pandemic or for any other reason, when you get off of this session today, please pick up the phone and make that appointment. Okay, next slide. And I just want to talk for a second, transition from what I just said into communal obligation, because so much of our lives focus on our communities, right? How do we care for ourselves? We delay. And even when I tell people, but you have to care for yourself just the way you would care for any loved one. How can you not? You're so important. Sometimes I'll get a nod and a yes, but. So for those of you who are thinking, yes, but, I'm going to reframe it. How will your children, whether they're 3 or 33, know that it's important that they care for themselves unless they see you caring for yourself? How will the women you volunteer with, the people you sit next to in show, know that this is an important thing to do unless they know other people around them are doing it? So your behavior, you're not only going for your mammogram, but letting people know in an appropriate manner, of course, that you've gone, that's modeling behavior. That's communal leadership, right? That's building a healthy community. And that is so important. And as Atar mentioned halachically, also right in line with what we believe and what we do. So don't just make that appointment. Tell your best friend on the walk you're going to take tomorrow, I finally made my mammogram appointment. You've had yours this year, right? Things like that, no pressure, not revealing embarrassing information or anything, just letting people know that this is appropriate behavior that needs to be done and things like that. And my last thought is, if you're looking for more information, if you're looking for support, there are a lot of organizations out there that can help you. I mentioned JScreen. Sharsheret can help not only if you're concerned or have questions about genetics, or support you if you're facing a mutation or cancer itself. We also do programs to help educate the community about these issues. So check out our website, learn some great information, help educate your community, and be the leaders that we know you all are. And now I'm going to turn it back to Atara, who's going to address, again, some of the halachic concerns related to what we just spoke about. Atara, you need to unmute.
Thank you. Thank you. Thank you so much, Melissa. Thank you so much, Ellen, for that excellent information. So helpful. With our remaining moments together, first of all, I'd like to encourage anybody who has not yet put up a question that you have to please do so. I'm going to talk about 3 areas of halacha that intersect with these issues. The first is going to be issues involving tefillah and the mikveh. The second is going to be the permissibility or maybe the requirement to have elective surgery. And the third is going to be issues surrounding fertility. Again, each of these issues is literally an hour and a half talk in and of itself. What I'm doing right here is opening up some questions. Bringing some issues to the forefront, because I think that it's important to have that awareness and that sensitivity, that idea of what we're dealing with, because I think that we always want to frame our everything in our life through the lens of halacha and through the lens of Jewish hashkafa. The first thing I'd like to talk about is mikveh. There's been a tremendous move towards educating balaniot. The women who help other women go to the mikveh are really unsung heroes. They work strange hours. They have to deal with a lot, and they really are women who generally have such a love of Torah and such a sensitivity, but they weren't always full of knowledge. They sometimes didn't know things that were very important. There's been a very strong movement towards working on mikveh sensitivity in all arenas, dealing with women who have had trauma, women with various health issues. One of the, and psychological issues, those are, by the way, just as a plug, those are addressed in a variety of other sessions in this conference. Please go check them out. In dealing with women have had either a prophylactic double mastectomy or women who are having cancer treatments, there are some particular concerns I'd like to just make you aware of. I'd like to use the words of Avigail Rock, the talented, exquisite, unbelievable Jewish educator who passed away from cancer recently, from breast cancer. A few years ago. She really, when she was diagnosed, she got into the field of educating about this because she really came at from a personal place. And I'd like you to listen to her words that are part of a longer article. She said, I wanted to convey to the balaniot, meaning she was part of training balaniot. Balaniot are the mikveh attendants who help the women tovel, that as hard as it for many women to stand naked in front of them when you don't have a breast, and you yourself don't want to look at it, it's really hard to undress and feel that you have to subject someone else to seeing your body. Even if they're the most wonderful and kind ladies, all you can think is, what will she think of my body? that's really one of the first primary things that balaniot have to understand. What can a body look like with all sorts of medical things? It's important that they look and that they've been exposed to pictures or are prepared for what somebody could look like when they're missing breasts, when they might have a port, all sorts of different things, so that they don't, God forbid, show anything on their face when they see a woman's body. There's some emotional issues. Realize that a woman who is toveling, maybe it's the last time that she's going to tovel for health reasons, or maybe because she had her ovaries removed and she no longer is going to become tmeya through having a period. Understand that. Be supportive in the moment. Always be aware of what's going on in the background and be there as emotional support. It could be that because of medical reasons, she needs to make her appointment at a strange time because she's having treatments. She might have to have the first tvila of the night because she needs to have the cleanest water. Her doctor said, yes, she could dip. By the way, just as a plug, sometimes women will say, my doctor said I'm not allowed to go to the mikvah. I always advocate, because I'm having a treatment, I always advocate that the woman should say explain to the doctor, well, let me explain to you what a mikvah is like. It's chlorinated, it's clean, the waters, we drain all the water, we Clorox the sides, we add the water, and then we add chlorine. Can I go into the water for literally a second? In that case, sometimes the doctor will say, oh, I thought it was like the public swimming pool. It's important to understand what's involved there and to have the first appointment, to have the cleanest mikvah, or have it at a strange time for a woman who's too exhausted or preoccupied with other things to be able to go to the mikvah. The second thing I'd like to talk about is the concept of prophylactic surgery. I think we all accept the idea that if somebody, God forbid, has a cancer, that surgery has to be done with all the attendant risks in order to remove it. But what if a woman is healthy? At this point, all she has is the gene. We're removing parts of her body really to prevent something. But the truth is that there are some halachic concerns. Two main ones. One of them is something called chavala. We just read in our parsha a few weeks ago that there's an isur, there's a prohibition against seret lenefesh, or ketovet ka'akua, that a person is not supposed to intentionally destroy their flesh, which was a common mourning ritual, or get a tattoo, which was part of avodah zarah. That's really the oraita. The Torah level prohibition of a tattoo is actually if it's done as part of a religious ritual. So what about a woman removing her ovaries, removing her breasts, and then part of having reconstructive surgery afterwards, which often can involve tattooing a nipple on, areola on, or something like that. So the truth is that we really say that is permitted, because again, going back to the original issue of nishmartem od lenafshotechem, that we have to guard our souls, and chavala, destroying our body, is really only when we're doing it for bizayon, to embarrass ourselves. We're doing it as part of idolatrous practice. We're doing it for its own sake, but that's limited according to halachic authorities. That it doesn't apply. Destroying our body or harming our body is not an issue if we're doing it in the service of ultimately making our bodies healthier, or even in the case of tattoos, or by the way, even some cosmetic procedures, if there's a psychological benefit, if there's an emotional benefit, then it's always going to be a risk-reward conversation. And if after consultation with doctors and psychologists and social, all those people, it's decided that the risk is worth the reward, then halacha permits it. By the way, as a side point, there is a debate in halacha among modern poskim, modern commentators. Is it that people are permitted to have their surgery, or are they required? There are those, Rabbi Blythe, Rabbi Willig have been quoted in saying that if it's clear that there's a medical benefit, that they're not just permitted, they're actually required to have their surgery. Again, this is not a halachic psak. I would ask somebody who is skilled in medical halacha these questions. But also you should just know that not everybody says that it's required, obviously, because especially with the prophylactic surgeries, there's so much nuance. There's also, like Melissa talked about, the psychological that many women, I think Ellen also talked about that there definitely are women who choose not to have the surgery and to do very vigilant screening. That of course is a very valid choice, because we wouldn't force somebody to have their surgery when there are other options open and there are other ways of making sure that we're healthy. Another issue involved is serous, something that's called sterilization. That if a woman is having an oophorectomy, she's having her eggs, her ovaries removed, her fallopian tubes removed, and also sometimes having a hysterectomy, and her uterus is going to be removed, and then at that point she's not able to have children. We know that there is a prohibition against serous, which is sterilization. So if you might remember a little quiz that I'll pause. Women generally have their ovaries and fallopian tubes removed when they've already had children. So it's actually much less of an issue if a woman has already had children, then we're not as concerned about the sterilization, again, because there's a clear benefit. If a woman, by the way, has not had children and she wants to have children, then there's a whole other arena, which, by the way, there's also a session, Batsheva Maslow was talking about egg retrieval. What about egg freezing, right? That is definitely an option. A woman can use a gestational carrier. Again, halachic issues involved with that, but solvable. Retrieving eggs that she can have biological children later. Adoption, all of those, which women, by the way, are not obligated in Pruavu anyway. They definitely get a mitzvah for procreating and having children, but there are definitely many other ways that women can have children, biological and otherwise, and those are certainly super valid and very important. I'd like to talk a little bit about again in that arena of fertility. There is a concept of PGD. Also a session on that if a woman is having IVF, which involves egg retrieval. I'm sorry, let me preface and explain. If a woman is a carrier for BRCA, she might say, listen, I've had a hard time with it, all the anxiety, the treatments I've had to undergo. Listen, I know that I'm a carrier. When I have a child, I like to ensure that my child is not a carrier. So it's possible to do pre-implantation analysis of any embryos that are fertilized outside of a woman's womb, and look through, microscopically, pull out a few cells, look at these cells, and say where is the BRCA gene here. So if a woman is a carrier, it is possible to go through IVF, retrieve her eggs. She can have them fertilized, and then they're analyzed to see which ones are carriers for the various BRCA genes, and then the ones that are not carriers can be implanted back in her uterus. So that brings also, again, plug for another session. You could do PGD and halacha the entire session. Just something to think about, that there's actually an amazing article on the Layers platform by a woman who did go do IVF, and you could just Google it, and it was a searing description of, it's not a simple procedure. It's complicated, exceptionally expensive, involves shots and procedures at particular times, a lot of emotional investment. And some women say, listen, I'm not prepared to do that. And some women say, I think it's really worth it. And again, that's one of those conversations that I think it's important for people to say, what's right for me. And again, all of these things should be done in consultation with medical and halachic professionals to go through all those different issues. I'd like to end with this, kind of, this picture for me really sums up all the emunah, the faith versus effort, hishtadlut question. How much are we supposed to say, listen, I'm going to do everything that I can to make sure that I protect my health. I'm going to maximize procedures. I'm going to do, make sure that my children aren't carriers and all those different issues. And versus we have a concept that's called Shomer Pitayim Hashem, that God watches over a petty, somebody who's simple, somebody who's kind of oblivious, somebody who just kind of blindly walks along and says, I'm going to just walk around with my faith. As with everything else, there's no simple solution. There's no such thing as saying this is the right way to behave, that's the right way to behave. There's very, very intense questions, and there's can be difficult issues, but I think we're gifted, we're lucky to be living at a time when, thank God, we have the ability to take action. I'd like to sum up to say that both Ellen and Melissa, their bios are available. Their bios are here so that you are 100% invited to please go and look at their bios, contact them with any questions. They have very generously offered to be a resource to help you find other resources or ask them something quick. If there are any questions, then you could pop them up now. Otherwise, I just would love to thank you so much for joining. Thank you so much for Nishmat, for putting together this conference. There's an outrageous quantity of information that's here. And really fundamentally, I'd love to really thank Melissa and Ellen for giving up so much time. They are both passionate, amazing, smart, dedicated women who are literally devoting their lives to help women live as productively, as healthy, as safely, and as empowered as possible. I really hope that you take away from the message that this is an arena when there's a tremendous amount of empowerment, where your personal agency can really go a very, very long way. Thank you so much.
So we can give it another moment or two to see if any questions pop up. But while you're all typing your questions in, I just want to follow up on what Atara said. She mentioned several times, there are so many related presentations. If you just check out the schedule, and they were all recorded. I know that Sharsheret also has an exhibit where you can download some information on the platform, the conference platform. So definitely check that out as well.
So we were either very clear, or we were able to understand that no one can even ask a question.
They're all busy making their mammography appointments. That's what it is.
Right.
So
that is always a big takeaway. The truth is, I'll just anecdotally, it's just something that Melissa said that she mentioned. We're actually here reflecting 3 different countries. We have Canada, Israel, and America. I just made Aliyah, and there really are differences in the protocols. And I was in America, and my protocol is that I was supposed to get a mammography. I moved to Israel, and suddenly I don't get a mammography yet for another few years. So just something that we in our conversations, it was so interesting that I mean, I know the least about this, but Melissa and Ellen are so knowledgeable, and they would often have like these little conversations like, oh, that's what you do in America, that's what you do in Canada, and it was really, really fascinating to hear the differences in medical care in the different places. So again, thank you so much, and we'll sign off now.
Thank you.
Thank you so much.